Recording in progress. Assalamu alaikum, everyone. Good evening. Am I audible? Can anyone confirm?
Yes, ma'am.
So who are our mock candidate? Please raise your hands. I know 3-4 people should join as a mock candidates. Okay, so those who do not know me or maybe not in my batch, I am Dr. Tamanna Yasmin, specialist pediatrician in NHS. So welcome you all for today's our clinical session. We had 4 candidates. I like to introduce you with them. Please, can you guys raise your hands up so that I can identify because I forgot the name. Dr. In, Dr. Noor, Dr. Danila, and Dr. Tharshni. Dr. Tharshni, where is she? Are you here, Dr. Tharshni? Okay. We will start now. We have planned some interesting cases. That's why I posted the link in our group so that you can all join and enjoy the mock session. And these are our past candidates in last 3-4 months. Alhamdulillah, they all passed from our batch in one chance. So let us start without any delay. If you have any question, please you can raise your hand so that I can give you the floor to talk, okay? And if you have any question, you can message also. But during the mock time, please do not interrupt the candidates, okay? This is the only request. Anyone has any question before I start? A short and quick question so that I can answer before I start. Anyone has any confusion? All right. So we will start with a video clip first, okay? Who will give first, Dr. Vin or Dr. Danila? Who has late night now?
I am MSK station.
Okay, Dr. Vin. Who is video station? Dr. Danila, right?
Yes.
So shall we start with the video first?
Yeah, if someone is late night, I don't mind if someone else want to start.
You are in UK, right?
In Spain, but it's the same. I'm 1 hour behind you.
Okay, Dr. Noor, I know she's in UK. So Dr. Vin, you like to start with this case first?
It's
Okay.
all right.
Okay. So this is a 4-year-old girl. Okay. Your task is lower limb musculoskeletal station. Her name is Laura. She is 4-year-old. All right.
Yeah.
You need any time to prepare or you just start?
4-year-old Nora.
4-year-old Laura, yes.
Okay. Can
You
I
start.
start?
Yeah, please start.
So
Mia, please add people, okay? I'm making you co-host.
Yes, ma'am.
Okay.
So I entered the room. I washed my hand and I introduced myself to the examiner and Laura. Hi, this is one of the pediatric registrar here, and I handed over my machine to the examiner, and I introduced my Laura. Hi, Laura. Nice to meet you. How are you doing?
She's submental actually. She's not understanding. She's not giving you any answer.
All right. Before I proceed anything, I would like to plot her height and weight, including occipital circumferences to the appropriate chart.
Okay. So height and weight are short. She's below 3rd centile of her short chart. And OFC, occipitofrontal circumference, is also on the lower centile, 4th centile.
All right. I could appreciate she is not in distress. And is there any device attached in the surrounding?
No.
All right. And the most obvious feature I could appreciate is that there is a polytethary and there is a bilateral knock knee. I would like to ask some screening questions to Laura's mother. Hi, ma'am. Is there any problems in walking and going up the stairs regarding Laura?
Yes, doctor. She cannot go upstairs, downstairs alone. She needs support.
All right. And do you mind if I examine Laura? Is there any pains, any stiffness in Laura?
No pain, no.
Thank you for letting me examine Laura. And so is there any problem in getting herself dressed?
No, doctor, she can't do alone. She need help.
All right. And so ma'am, could you please can I ask Laura to walk? Is that all right?
Yes, doctor, she is walking, but the gait is not normal due to the knock knee. Her
Mhm.
gait is a little bit clumsy,
All
but
right.
you cannot describe the gait by any chance. It's clumsy.
All right. Got it. And so is he able to walk tiptoe?
No, she can't.
It's all right. And so in the meantime, I will inspect the back. Is there any problems? Is there any scoliosis? Is there any scars in the back?
No.
So is there any muscle wasting? Muscle wasting. Is there any contracture apart from the knock knee? I inspect from behind. Why she is walking?
Yeah. So there is no muscle wasting, no muscle hypertrophy.
Is there any scars, any deformity apart from knock knee?
No.
All right. I so there is no scoliosis, isn't it?
Yeah, no
Oh,
scoliosis.
all right. So I request Laura. Hi, Laura. Could you please lay down on the back?
Okay, she's lying down.
And I proceed the lower limb care. The most obvious feature is the bilateral knock knee. So I would do the I will do the knee joint examination first. So in the I could appreciate there is a bilateral knock knee. But apart from that, is there any deformity contracture in the lower leg?
You can see the lower leg, right?
Yeah.
And contracture you will feel when you palpate, right?
All right. I saw I will feel the temperature by back of my hand around by both the knees. Is there any raise in temperature? In the meantime, when I feel the temperature, I go see I will see the Laura's face. Is there any tenderness?
No, no tenderness.
Yes. And I'm gonna appreciate any joint swelling, but I want to do the patella test. Am I able to do patella test?
Why you will do patella test? Did I mention any swelling in the knee joint?
There is no swelling.
Yes.
Okay, so I skip it. And so I will request Laura. Hi, Laura, could you please bend your knee?
Yes, she can bend, but not fully bend. So it is restricted. Movement is restricted.
All right. So I'm gonna proceed the active movement slowly and ask Laura. Hi, Laura. I'm gonna do some movement regarding your knees. Is there any pains? Please do let me know. Is that all right?
Yes.
So I'm gonna do the knee flexion and extension. And so what both sides? What is the what is the range of movement? Who needs?
Restricted. It is not due to pain. She has no pain, but restricted.
All right. So range of movement is restricted both active and passive movement. Is it correct?
Both active and passive
Passive
restricted.
movement. All right. So I would like to proceed the hip joint. I gonna appreciate any joint swelling, any deformity. So I would like to do the range of movement. Laura, could you please raise your legs above the ceiling?
Yes, she can.
All right. So Laura, could you please could you please lower down the legs and could you please move both legs away from the body? Is
Yes,
able to do.
can.
And in contrast, Laura, could you please move both legs towards the body line? I'm gonna check the adduction ADD.
Yeah, she can, but during abduction is okay, but abduction is restricted. She cannot do the abduction in full range.
ABD meant.
I mean abduction, ABD.
Abduction, okay. Or ADD, correct. And so I would like to proceed the passive movement by flexing the hip joint and also make the knees 90-degree angles and do the active movement by checking the flexion and internal rotation.
What is the movement? Hip flexion and hip extension, right?
Hip flexion and internal rotation by
Our-
doing this like yeah.
Okay, yes. So by doing the 90 degree to the hip, then moving the hip medially, right? By doing 90 degree,
yeah,
you
yeah.
show you can show on the doll to me, Dr. Vin.
My dog is the leg is very short, that's why. I cannot move because his leg is he's like achondroplasia right now.
Okay, okay, do that short leg, no problem.
Okay. So
why
this is a leg. So it's a I do it like this. It's a
Yes, and then
yeah. And then this is a internal rotation. This is a flexion. So I do it like this.
wait, Dr. Vin, take a breath, slow down. Yes, show me the internal rotation and external rotation.
So this is the hip. This is a knee. So I'm gonna do like this. Stabilize the hip joint. And I'm gonna do like this. It's the internal rotation. This is the external rotation.
Right, right. And
Here.
what is flexion and extension?
Flexion and extension is the knee joint.
Hmm?
It's flexion. Sorry. Flexion is the pull the knee towards the buttock. It's a flexion.
No, buttock extension, front flexion. The
Oh.
hip joint move front, that is flexion. Hip joint move backward, that is buttockward. That is
Got it.
right?
Oh yeah.
Yes. So if I show you by my hand, I don't have any doll as well. So if I show you guys by my hand, if you can see my hand, you can see it. So this is the yeah. So this is the hip joint, okay? So hip joint move forward. If you move forward the hip joint, this is flexion. If you move forward the hip backward the hip joint, this is extension. And 90 degree angle, if you move the hip like this is called internal rotation. This is called external rotation. And if you move hip like this is called internal rotation. But when you go like this, your ball and socket joint is going outward. So that's why it is external rotation. And when you go like this, your ball and socket is going internally. So this is internal rotation. Okay. So hip flexion, hip extension, then external rotation, internal, and abduction. Adduction is easy. Abduction means away. Adduction means towards the body. So this, wait, I am stopping my video first. Wait. Yes, my video stopped. So that is the 6th movement of the hip joint. I showed you now because later on I will forget that which one you are doing. So
I could not see your hands. I only see the video.
You only see my video? Okay, no problem. We will share the picture. So hip flexion means hip joint forward. Hip extension means hip joint backward. And hip external rotation means in 90 degree angle, you are moving the hip towards your body. Then the hip joint will go outward. This is called external rotation. And in 90 degree angle, if you move hip away from the body, and then the hip joint will go down inward. So this is called internal rotation. So this 6 movement you are checking, right? We do not check circumduction in hip joint.
Yeah.
So this 6 movement is restricted. Now what you want to do?
I'm gonna move to the ankle joint movement. So I request Laura, hi Laura, could you please push your toes towards you to check that dorsiflexion?
So it is also restricted.
And could you please point your toes towards the back?
It is also restricted. So bilaterally, all the joints are restricted, but there is no pain.
All right. And so I complete my examination by doing an upper limb because and also I would like to measure true length and I like to measure the upper segment lower segment ratio because he's a short stature, and I would like to complete my examination by doing cardiovascular examination and also knee examination and also teeth examination and developmental assessment.
Okay, very good. What is your diagnosis?
It's a 4-year-old Laura with probably control abdominal dysplasia. And because the striking features are his bilateral knock knee, and there is a developmental delay, and his lower limb movement, range of movement are restricted both active and passive movement due to the contracture, although there is no pain. And I could appreciate there is a post-axial polyteterally and also has short stature as well.
You said ectodermal dysplasia.
Control ectodermal dysplasia is an elephant's cleavage syndrome.
Right. Don't mention ectodermal dysplasia. It is chondromesodermal dysplasia. It is not ectoderm. Chondromesoderm, okay? It is called Ellis Van Creveld.
Ellis Van Creveld syndrome.
I heard you said ectodermal dysplasia.
Yeah, I said. Sorry for my first.
No. Yes, that's why I avoid that dysplasia word. Say it is Ellis Van Creveld syndrome.
Ellis Van Creveld syndrome.
Okay? Okay. All right. So what are the positive findings for Ellis Van Creveld?
Yes, it's a short stature, development delay, and bilateral knock knee, and also has some usually post-axial polyteterally, and also has some knee deformity and teeth deformity as well.
Okay.
And also associated with cardiac abnormality, especially ASD.
Okay. What is ASD?
Oh, sorry, atrial septal defect.
Yes, because ASD also means autism spectrum.
Autism disorder, yeah.
Yeah, so don't use abbreviation to the examiners. So other than ASD, other than atrial septal defect and the bony deformity, what other features you can find in Ellis Van Creveld?
Bone deformity,
Okay.
and also short stature, disproportionate short stature.
Okay.
And upper segment, lower segment may be raised here.
Okay.
And also has some developmental delay.
Yes.
And also has some features of knee deformity and also teeth deformity.
Sorry, what?
Teeth deformity.
P mane ki? What is P?
Teeth.
Teeth.
Yeah.
Okay. Teeth, yeah.
Teeth and knee deformities.
Teeth
And
deformity,
also
bony
knee
deformity.
deformity.
Yeah, because it is mesodermal problem, right? It is not ectodermal problem. And teeth is mainly formed by ectoderm, mesoderm, both. Okay, there are pulp, dental enamel, right? It's a anatomical classification of ectoderm, mesoderm, and endoderm. So mainly Ellis Van Creveld is mesodermal defect. They have chondromesodermal. Chondro means cartilage. So they have cartilaginous problem, and they have mesodermal problem like hair fall, teeth problem also. Not hair fall, teeth problem mainly, teeth problem. And
also versus.
mesoderm is related with cardiac septum, right? That is also ESD, right? Midline defect. They also can have connective tissue problem like the lungs. So they can have restrictive lung disease. Okay. And why the restriction? Why the joints? All the joints are restricted.
Because of contracture.
It is actually bony deformity, bony contracture. Yes, it is not due to pain, not due to swelling.
Yeah.
How will you investigate? I'm not still did not give your correction of the exam, but we are finishing the discussion. Then I will go back. Okay. So tell me, how do you investigate? What type of disease this is, Ellis Van Creveld?
It's autosomal recessive.
Okay.
Yeah. So I would like to do genetic studies, and I would like to do genetic study for diagnosis, and I would like to do X-ray of both knee, including hip joints, and to find out is there any associated deformity apart from the knock knee, and I would like to do also hand X-ray because there is a polyteterally I could appreciate. And I would like to do some bone profile, calcium, phosphate, magnesium, and parathyroid hormone to check is there any anomalies. And I would like to do some basic blood tests like the full blood count, and also liver function test. And I would like to do a check X-ray ECG to find out any associated with cardiac abnormality or any respiratory like the restricted lung disease. And I would like to do also lung function test, spirometry to check out is there any associated restricted lung disease.
Okay. How will you manage this patient?
And she should be in under the multidisciplinary approach teams, and he should also be liaised with the auto surgeon to correct his knock knee, and also he should be do regular physiotherapy, occupational therapies, and also auto test to make a special shoes and also any other auto supportive measures. And also he should be under the development pediatrician for development assessment, and he should be under proper hearing and vision assessment by ophthalmologist and ENT specialist. And if there is any associated with restricted lung disease or any repeated chest infection, he should be liaised with respiratory physician. And he should also be liaised with a plastic team to correct his polydactyly. And he should also be liaised with cardiologist for the associated with cardiac abnormality.
Very good.
And also, yes, that's it.
Orthopedic also you mentioned, right? Orthopedic team must
Orthosis, yeah.
orthosis, yeah. Plastic surgeon for the removal of extra digit, right?
Yeah.
And cardiac doctor
Cardiac oriented.
for restrictive lung disease.
Yeah. Respiratory physicians.
Yeah. And physiotherapy, physiotherapy, occupational therapy, developmental pediatrician. Did you mention genetist?
Oh, I forgot. Yeah, genetic for because it's a genetic disorders, and she should also be DRA support and also EACP because he has the development delay. I forgot to mention that. Yeah.
Yeah. So special educational programs, SENCO, or educational healthcare plan will be made because these children are developmentally delayed, intellectually impaired also. And there will be requirement of what is the role of occupational therapy, do you think, in this child?
Especially for fine motor movement.
And
also for daily activities like brushing, walking, brushing, and eating.
If I say home modification, school modification.
Yes, it's also included here. For
Right.
occupational therapy, yeah, it's a role, yeah.
Therapy, yes, because he has problem in movement, no? Restricted,
Yeah.
clumsy child.
He
Okay.
should also be liaised with dentist because I forgot to mention this. So important.
You forgot dentist.
Yeah.
And if the child had scoliosis, then also you have to involve orthotic team for braces.
Yeah, I did mention, yeah.
Braces, yeah. So it is a multidisciplinary approach, right?
Yeah.
And eye care also, skin care, eye care, dental care. Although this is mesodermal problem, but skin, eye, they can be involved. Mesoderm is there, right?
Yeah.
All right, very good, Dr. Will, very good. So let us go back to your approach. What do you think? Your approach was perfect?
I don't know, actually.
You don't know. You are very cute. Listen,
Thank you.
your approach was good, but you took too much time to go to the leg. You should not waste your time because after the exam, you have to do the general physical examination. After the systemic approach, we should go to the general physical examination, right?
Yeah.
So you should not do too late. You should be very hurried. Leg gate back first. Check the leg, check the gate, check the back. Everything you checked. Any pain anywhere, any difficulty in going upstairs, downstairs, or dressing up, down, and any problem in handwriting or utensil. Bas, these are the screening question, right? And then directly jump onto the lower limb, piggle, tell the child to lie down, and then start inspection. Inspection, full body. And then start your movement because there is no local joint swelling. So we will not do any local joint problem like temperature, tenderness, effusion. This is local joint examination, but we will not do local joint examination because there is no joint swelling, only contracture and only deformity. So here we will escape the local joint. But yes, you can do some palpation like temperature, but not fluctuation because there is no swelling. You can just check temperature, whole, just back of your finger, temperature check that is there any joint raised or not. Then directly start the child, talk with the child. You did talk with the child. Do you have any pain anywhere? You did that. So talk with the child that, do you have any pain? I'm going to start some movement on your leg. If you feel pain at any point, please let me know. This is how you will approach. Okay. Then what will you do? You will go to the leg. Then you will start either from lower part to upper part, or from upper part to lower part. What you did, you started with knee joint, then you went to the hip joint, then you went to the ankle joint. Am I right? So
Yeah.
it was a little disruption. I'm not saying you are wrong, you are right, but you did a little haphazard. You have to start from the lower leg. Yes, ankle. Then flexion, extension, inversion, eversion. I think you forgot inversion, eversion for ankle,
Yes,
right?
I forgot. Yeah.
You
I
did
forgot inversion.
extension, inversion, eversion, you forgot. And then you should go to the knee joint. Knee joint has two movements, flexion, extension. And then you should go to the hip joint. Tell the child to do first. This is called active movement. If the child cannot do it, then you will do passive movement, right?
Mm.
Next is hip joint 6 movement. You also could not demonstrate 6 movement properly. Flexion, extension, right? You forgot.
Yeah. Yeah,
Flexion.
flexion, extension.
And you forgot inversion, eversion. If the examiner is very careful like me, examiner will mark it. Okay, but if examiner is very easygoing, he may not notice that you did not do complete examination. But as I noticed, examiner will also notice, right? So 6 movement of the hip, 2 movement of the knee,
Four
and
movement on
4
the ankle.
movement of the ankle joint you have to do. This is the piggle part. So before piggle, what you did, you just inspect and you just check the temperature and tenderness is present or not. You did not do any fluctuation because there was no fluctuation, there was no swelling. Then you already checked back, there was no scoliosis, but scoliosis is invariably common in musculoskeletal children. So you should do bend forward and see that the scoliosis disappear or not. But this child did not have any scoliosis, so we did not check. Now, after that, we should go to the upper limb piggle because although my task was lower limb piggle, that's why I told you, you have to do very hurry because you have to finish the piggle and then you have to do general physical examination. You have to do the piggle. Upper limb piggle is very short. Just tell the child that, do you have any pain anywhere? And then prayer sign, reverse prayer sign, flexion, extension of the elbow joint, and abduction, adduction, flexion, extension of the shoulder joint. Just few movement. You should not do all the movement. You should check that is the restricted lower limb also associated with restricted upper limb. Okay. Then you would comment to the examiner, sir, this child has generalized joint restriction and it is a generalized condition. It is not only involved the lower limb, right? And during upper limb examination, you should also notice that there was short and broad hand. There was polydactyly, postaxial polydactyly. You should also notice, is there any scar mark on the hand? Why? Maybe some surgery or polydactyly removal. You should also notice. Then after the movement part of the upper limb, you should directly tell the examiner, sir, I have completed my musculoskeletal examination, but I feel the child looks unusual facies. Don't say dysmorphic, okay, in front of the mother. Dysmorphism means something bad. So don't say dysmorphism. Say that, sir, there are some unusual features. I can see the child, so I will do some general physical examination. And when you assessed 4DSP at the beginning, remember, Dr. Evin, you did not tell me that, sir, I like to know, you told me, sir, I like to know the height weight. I said below third centile. Then immediately you should say, sir, I like to measure the sitting height and standing height because I like to measure the upper body and lower body part. Okay. And then when the child was standing, you should also do some make a fist, make a star, because the child has polydactyly, no? And make a fist, make a star, and the keep your hand on the side of the body because the hands are not reaching. You see, the hands are not reaching onto the mid thigh. Normally, a hand should reach the mid thigh. So the hands are not meeting to the mid thigh. So you will say that, sir, I feel that the limbs are short than the trunk. So I like to measure rhizomelic, mesomelic, and acromelic shortening. So I like to measure from acromion process. I like to measure from the upper end of the shoulder to the elbow joint, and then from the elbow joint to the wrist joint, and then from the wrist joint to the tip of the finger, middle finger. This is how you will, normally our body parts are equal. So the humerus, radius, ulna, they are equal normally. But here you will find there is some rhizomelic shortening. If you see, there is some rhizomelic shortening. Sometimes you will find there is mesomelic shortening. This child also has acromelic shortening.
Yeah.
Okay, so this Ellis Van Creveld are different types, type 1, type 2, type 3. Okay, in some part there is rhizomelic shortening, in some part there are mesomelic shortening, in some part there is acromelic shortening. Okay, or sometime it is combination, but this child definitely has short limb than the short trunk. Short limb, am I right? Short limb.
Yeah,
So
shoulder, yeah.
yes, so you should measure this and you should offer this. The sir, I want to measure the upper body part and lower body part. I like to measure the ratio. Examiner will ask you, what are you expecting? You will say,
Please.
sir, this is looks like disproportionate short stature because the limbs are bowing. So I will find that upper body, lower body ratio will be increased.
Increase.
Normally, how much upper body and lower body ratio?
Usually after 8 years, it should be 1:1.
Right. At 4 year, it is 1.4:1, right?
Yeah,
And 8 year, it is almost 1:1.
1:1.
He's 4. He is 4. Normally, his upper body should be 1.4 normally. But here in this child, you will find 1.8, 1.9.
More increase, yeah.
4 increased. So examiner will not go into detail, but examiner will ask you, how will you measure upper body and lower body? So you know, right? First, I will measure the full length of the child, and then I will make the child sit down on the
Sit
chair.
down.
And from the upper part of the head to the point of the chair
buttock.
when it's sitting, buttock, that
Yeah.
point we will measure. That is the upper body part.
Upper segment. And
That is upper
to
segment, and we will deduct from the whole body length. Yes,
it should be lower segment.
yes. And this child can have leg length discrepancy. So offer the examiner. You will not do all this thing. You can ask me, madam, I will do all this thing in 5 minutes. No, you will offer, just offer that, sir, I feel there is up lower body disproportionate as well. So I like to measure the leg length discrepancy in this child. Am I right? And you know, right? If there is a knock knee, how we measure the leg length discrepancy? You know, right?
Yeah, from the exercise to the pattern to the design knee.
From the anterior superior iliac spine to the
And
medial
to the medial malleolus, and then here to the medial malleolus.
Sorry, not medial malleolus.
In
To the
the
anterior superior
patella.
iliac spine to the patella.
To the patella to the medial malleolus.
So we will measure like this because this child has disproportionate lower limb. So we will measure part by part. We will measure first from the anterior superior iliac spine to the tube. What is that called? Tibial tuberosity. And then from the tibial tuberosity to the medial malleolus. And then we will suppose this is 20 centimeters. Suppose, and this is left leg 20 centimeter, and right leg is 18 centimeter. Up to 1 centimeter is okay. Up to 1 centimeter disproportionate is okay. But if it is 2 centimeter, 3 centimeter disproportionate, then we can say there is a leg length
discrepancy.
What is the cause of this leg length discrepancy?
It may be due to the contracture.
Yes, right. Due to the contracture. It is not due to developmental dysplasia. It is due to contracture because they have all the joints contracture because of the chondrodermal problem, chondrodermal dysplasia, right?
Yeah, it's a true limb length discrepancy. Yeah.
Right.
Yeah.
And also the thorax, if you see short thorax, this is also a feature of the, because ribs are short thorax, it is also a feature of the Ellis Van Creveld syndrome. And you have to do, lastly, you have to do general physical examination, sir. I like to know the teeth, vision, hearing, and heart and lungs. Okay, they usually do not have kidney problems, so abdomen, we don't need it. We need heart, lungs, because they have ASD, VSD, PFO, and we need lungs because they have restrictive lung disease. We need vision check, hearing check. We need teeth, dental anomalies they have. We need teeth check, okay? And lastly, we should do developmental assessment. And the treatment investigation, as you said, multidisciplinary approach X-ray of the different parts of the body, because there are, contracture and there are joint deformity. So how much is the deformity? How much is the contracture? You should do by X-ray. And it is a genetic testing you can do. The gene name is, I think, EVC gene. Okay, EVC gene. You can do the genetic mutation testing, and then you can do hearing testing, vision testing, then heart, echocardiography, chest X-ray for lung disease, right? These are the investigation. X-ray of the spine, if you suspect there is scoliosis, X-ray of the spine, and X-ray of the ribs, chest X-ray. And then management, as you say, developmental assessment, respiratory physician, cardiac doctor, then dental doctor, eye specialist, ENT specialist, okay, and pediatrician, and genetic doctor, and school will be involved, social service will be involved, disability living allowance will be given. That's all. No examiner can ask more than this question. Okay, anyone has any question?
Hi, ma'am. Is it possible if I offer the upper segment, lower segment ratio in the list?
It is possible. Yeah, examiner will not
Okay.
mind. Don't forget. Don't forget.
I did mention in the list.
Yes, you prefer in the last. Yeah, you can do short stature approach in the last. After doing
Right.
the upper limb, lower limb, after doing the teeth, eye, you can do short stature approach a little bit, like, make a fist, make a star, put your body, put your hands down, put your hands shoulder on the shoulder, shooting, overshooting, undershooting. Okay. If the shoulder, if the hand cannot reach up to the shoulder, this is called, we call undershooting, right? In case of isomelic shortening, there will be undershortening. Undershooting. And if the child has mesomelic shortening, there will be overshooting, right? So undershooting, overshooting test, you should show to the examiner that, sir, I know these procedures. I know, I can see this, okay? Because this child has definite short limb. All right? Very good. Well done. Excellent. I did not expect that much better. You did very good. Just missed few points. That is more natural because you are student, so you will miss something, of course. We will
Thank you very much, ma'am.
Thank you. We will turn to Dr. Noor. Dr. Thashni will not give today. Dr. Noor, your station is what? Neuro.
Yes, ma'am, neuro.
Who had video station? I prepared one video station.
Me, ma'am, Danila.
Danila. Where is Danila?
Sorry?
Okay. Your hand is not raised. That's why I cannot.
Ah.
I'm searching you. Where is Danila? Yeah. Okay. So I'll take the video now, and then I'll take Dr. Noor's neuro. Okay.
Okay.
Okay. So this is our video station for Dr. Danila. How to measure mesomelia from where to where? Actually, there are fixed landmark, like from the tip of the shoulder. This is called acromion process, right? To the, what is that called? Ulna, tip of the ulna, radius and ulna, you will measure the rhizomelic shortening. And from the tip of the ulna, head of the ulna, then you will measure to the, what is that called? This tubercle, lower end of the ulna, you will measure the mesomelic shortening. There is no definitive point, but the bony prominence, you will measure from bony prominence. Normally, the rhizomelic and mesomelic part are equal in our body. But if you see that one part is short, then we say it is rhizomelic shortening or mesomelic shortening. Okay, it is from the bony prominence you will measure. All right. Okay, this is the video. Just let me know, can you see the video or not? Everyone, okay? This is a 5-year-old boy. Okay, Dr. Danila, this is a 5-year-old boy. He is short stature. He has short stature and repeated convulsion. History of repeated convulsion. And he has short stature. And this is a video of eye. Can you see the eye is moving?
Yes.
Okay. So 5-year-old boy who has history of repeated convulsion and who has short stature from birth, he is having convulsion, okay? So this child is from the Asian country. You can see the tilak from the Asian country, undiagnosed, okay? If the child is in Europe or UK, then maybe he was diagnosed, but he's undiagnosed case. So this is the eye movement of the child at 5 years of age. The child has short stature, repeated convulsion. So your video will start after 3 minutes. You will see the video until 3 minutes. Every time the video will play, okay?
Okay.
The video is clear, right? There is no drop
Yes.
out.
Yes.
Oh, okay. Yes, Dr. Danila, please start.
Yes, so I can see a 5-year-old child. He looks like he's at hospital setting. He has not any device attached. He has not present any dysmorphic features, and he looks okay for her weight and height, but I would like to plot him in appropriate row chart. I can see in the video that he present horizontal movement of the eyes. Also, my diagnosis can be an horizontal nystagmus.
Is it nystagmus?
I think so.
Okay, look carefully. Nystagmus means jerking movement. Is it jerking movement? Is it look like jerk? Or the child is searching something?
No, it's like searching something.
Yeah, he's searching something. Right and left. He's going right and left. It is not nystagmus. Nystagmus means jerk, like a myoclonic jerk. Here, it looks like he is searching something. What he is searching?
Well, I have to rule out any if the child has any increased pressure for a tumor, or if it is a vascular cause or infected cause.
Okay. I'm giving you some hint. The child is blind.
So I have to rule out if the child has a septic optic dysplasia, also because he is short stature.
Okay. So the child is blind. Okay. And
Yes.
the child has repeated convulsion and the child is short stature. You have to combine. You have to combine with the features that is given in the exam with the video. Sometimes the video will be very rare. Like this video is very rare video, one of the rarest video.
Yeah, I thought it was nystagmus too.
Yes, many people will do this mistake like you. I'm not blaming anyone, but just I'm telling you, if someday you see that the video is very rare, you don't understand what is the video, then what should you do? You should combine with the features that is given.
Okay.
You should combine the feature that is given. The feature is given that the child is having short stature, repeated convulsion from birth, and the child is blind. So any blind child, the movement, we call it a roving eye movement. He is searching something. Can you see the screen?
Yeah.
So this is actually roving eye movement. Predominantly roving eye movements are horizontal. Sometimes they can be vertical. This child has horizontal roving eye movement, right? And that means he's searching something. The forehead this is called tilak. Tilak means a good wish, okay? So this child is coming from Asia, a poor family, and he's undiagnosed. Okay, he's 5-year-old who is already blind, and the child is short stature with repeated convulsions since birth. So this diagnosis is a blind child, short stature with repeated convulsion. It is septoptic dysplasia. What is the clinical feature of septoptic dysplasia? So what history you will like to ask from the mother, Dr. Danila?
Yeah, so I will also ask about the onset, the cause, and the duration. And also, I would like to ask the prenatal, natal, and postnatal history, because one of the causes can be gestational diabetes. Then I'm going to ask the mother about any, if the child is taking any medication, if he has any hearing problems, cardiac problems. Also, I would like to see if the child has sleep problems, if he is obese, and I would like to ask the mother about any development delay.
Okay, yes, very good. So onset course duration of the convulsion, right?
Yes.
Is it related with food or even after food? Because you are excluding hypoglycemic attack,
Yeah.
right?
Yeah.
Is there any associated intercurrent illness? Was there any headache, blurring of vision? Okay, you are excluding other intracranial cause, right?
Yeah.
And since when the child having visual problem? Okay, and then what investigation done so far? What treatment was given so far? Was he admitted in hospital? Does he having developmental delay? What about the speech? What about the walking? What about the movement? Okay, so
Yeah.
detailed developmental history, detailed hospitalization history, then detailed past investigation, onset course duration of the convulsion, and also onset course duration of the visual problem.
Mm.
These are the history taking from the mother, and also anybody in the family, same affected or
Oh,
not.
yeah, family history. And also, I have to ask about genitalia.
Right. They also have genitalia, short genitalia, right?
Yeah.
So what investigation you will do for
Uh,
dysplasia?
Yeah, so I will do MRI of the brain and to check the pituitary fossa. And also I'm going to do blood test. I'm going to do growth hormone stimulation test, cortisol level, also FSH and LH, ACTH level, thyroid function test, and fundoscopy.
Why are you doing these hormones?
Because this patient can have an affection of the pituitary. It is a hypothalamo pituitary endocrine problem, septic optic dysplasia.
Yes, this is actually a problem with the hypopituitarism, right? They have
Yeah.
hypopituitarism problem. So you have to do baseline hormones test like thyroid hormone, growth hormone. But how you will confirm this is hypopituitarism? What is the confirmatory test for hypopituitarism? Stimulation test, right? Insulin
Growth hormone stimulation test.
hormones.
Insulin like growth factor. Yeah.
Yes. Insulin stimulation, glucagon stimulation, or you can do IGF stimulation. I mean the stimulation test. And even after stimulation, if the hormone does not increase, baseline hormone does not increase, then it is sure that it is hypopituitarism, right? And what hormone test you said you will do, and what test you will do?
The growth stimulation test, do you mean?
No. Other investigation other than hormone.
Okay, cortisol level, ACTH level, FSH, LH, thyroid function test, also adrenal test to check the adrenal, so sodium, potassium, glucose, and I have to check the BP.
And
I say fundoscopy and EEG because the child has seizures. Yeah, I think glucose test. And yeah, I think I covered all the tests.
Okay, the most important investigation you did not mention.
MRI of the brain.
Right.
Yeah, I say, I think.
Yeah.
And yeah.
MRI of the brain, yes. All right, so done. Investigation done. EEG, blood glucose, electrolytes, because they have adrenal function problem.
Yeah.
And also you have to do visual evoked potential test, remember?
Oh, yeah, I forgot, yeah.
Yes, visual evoked potential, because this child is blind. So you will see the stimulation in the brain,
Yeah.
visual evoked potential, EEG, MRI, blood glucose, of course, and baseline test, of course, and
Yeah.
all the hormones, as you said. And to prove that the child has hypopituitarism, you have to do all the hormones and insulin or growth hormone stimulation test. Very good. And how will you manage?
Well, I will involve a multidisciplinary team, like neurologist, ophthalmologist, optometrist, development pediatrician, genetic team, dietitian, endocrinologist, OT, if the child goes to a school support, the school nurse, and urologist maybe.
What is the prognosis? Prognosis is good?
Well, if it is diagnosed very soon, yes, if can have a good prognosis. But if not diagnosed on time, I think the prognosis is bad.
What about the vision?
Bad prognosis, no, because the child is blind.
Why the child is blind?
Because the optic nerve hypoplasia.
Aiva, very good. Yes, they have optic nerve hypoplasia. And that's why they even if you give like, if you treat all the condition, hypopituitarism and everything, you can prevent brain problem, but you cannot revert back to the eye problem. So they are actually, most of these child are blind.
Yeah.
Okay.
Okay.
All right. Anything else we missed? Septoptic dysplasia. What is the main pathology? Why it is called septoptic dysplasia?
Because midline abnormalities.
Yes. Midline? Which midline? What midline? What is the deficiency?
No, I can't remember.
They have absence corpus callosum
Corpus callosum, yes.
and septum pellucidum.
Yeah.
And also they have hypothalamic pituitary problem. So
Yeah.
there are different types of septoptic dysplasia, type 1, type 2, type 3. Some children has pathology in the septoptic problem like corpus callosum agenesis or septum pellucidum absent. Some children has problem in the hypothalamic pituitary axis. So the hormone from the hypothalamus is not coming to the pituitary. So they have problem in both anterior pituitary and posterior pituitary. Some children has problem with optic nerve hypoplasia. Some children may not have optic nerve hypoplasia, but some children can have optic nerve hypoplasia. So there are different types of septoptic dysplasia. How it is common? How much? It is 1 in 10,000. So it is not very uncommon disorder. And giving this video, the idea is blind child. You have to understand which child is blind. If you remember, few months back, we did one free session that has a glass eye.
Oh, yeah.
So
Yes.
glass eye, blind eye, artificial eye. Okay, these are very, very, very important topic in video station. And so septoptic dysplasia is a genetic disorder when there is a problem in the gene. It is sometimes it is familial, sometimes it is spontaneous, sporadic. Mainly it is sporadic. Sporadic means ki automatic, right? There is no cause, sporadic. And also it can be genetically inherited in the family. And mainly they present after birth with hypoglycemic convulsion. Later on, they become intractable epilepsy because of the absence of corpus callosum. They have epilepsy. So this child might have epilepsy plus they have convulsion, hypoglycemic convulsion due to growth hormone problem. And they have genitalia problem, congenital heart disease. Sorry, not congenital. They have genitalia problem because of the growth hormone deficiency. They have vision problem because of the optic nerve hypoplasia. They have intractable seizure, sleep problem, and developmental delay.
Yeah, ma'am, cardiac, I think that they have atrial septal defect. I'm not 100% sure.
In the patient info, it is not given, maybe, because syndrome can be associated. It is not like it's not like absolute feature, okay?
Okay.
Absolute features are hypopituitarism, hypothalamic pituitary axis problem, corpus callosal agenesis, and optic nerve hypoplasia. These are absolute feature. And genitalia problem is due to growth hormone deficiency, small genitalia. So these are the problems. So hormonal problem are related with growth hormone deficiency, then ACTH, so cortisol deficiency, ACTH deficiency, adrenal hormone deficiency, then they have diabetes insipidus because of the ADH deficiency, okay? They have precocious puberty because of the hormonal imbalance of the FSH-LH, okay? And they have thermoregulation problems. So during examination, you might see that they have cold, very cold body because of the thermoregulation problem. And there are different types, as I said, some type 1, type 2, type 3. And main investigation is MRI of the brain to check corpus callosum, to check septum pellucidum, to check the optic nerve diameter. Optic nerve diameter will be less than the normal. And then you will see management. Investigation is another one is pituitary hormone function test and pituitary hormone stimulation test, that is growth hormone stimulation test. And then you will do management is lifelong giving giving hormones like growth hormone for 16, 17 years. Then you will give lifelong cortisol because they have ACTH deficiency. Then you will give management of diabetes insipidus, that is ADH. Did you mention this individual hormone? No, I think no. Individual hormone lifelong. You have to
No,
yes.
I don't have time to check.
Yeah, so management of diabetes insipidus, management of Addison's disease, right? Management of growth hormone deficiency, management of sex hormone deficiency, okay? Management of vision problem, management of convulsion problem. So you have to rule out, you have to give it, refer to the neurologist for management of intractable seizure. They may need multiple drugs, okay?
Yeah.
All right, this is the management of septoptic dysplasia. All right, I think we finished. Any question? Anyone? So understand the glass eye, understand the blind eye, and understand the nystagmus. This is very important, okay? Nystagmus, squint, blind eye, glass eye, different varieties of eye problem will come in the exam. Thank you, Dr. Danila. Next, I'll go to
Thank
Dr.
you, ma'am.
Thank you. Dr. Noor, what exam, what station you have?
Ma'am, it's neuro examination.
Okay. Let me open your neuro. Can you see the child?
No, ma'am, not yet.
Okay. Let me share again. Can you see the child now?
Yes, ma'am.
Yeah. So his name is what is his name? Adam. Okay. Adam is 7-year-old. Okay.
Yes, ma'am.
7-year-old in wheelchair. All right. So
Yeah.
your task is lower limb neurology. 7-year-old in wheelchair.
Mm-hmm. So
Yes.
I'm handing over my mark sheet to the examiner, introducing myself. My name is Noor. I'm one of the candidates. I'm gelling my hands and I'm approaching towards Adam, sorry. Hi, Adam. How are you? My name is Noor. I'm one of the pediatric doctor here today.
He's smiling. He's okay.
Okay, so I'm going to examine your legs. Is that all right?
He's saying yes.
Okay, so I'm going to pull up your trousers a bit. Okay. I'm asking his mom to help me as well.
Yes, mom is helping the trousers, or you want to
Yeah.
check the leg, right?
Yeah.
Yeah, he is exposing the lower part of the leg.
Is there any devices around apart from the wheelchair?
No other device.
Okay. And is he in distress?
He's not in distress.
And I can't see any dysmorphic features. May I know his height and weight? And I want to plot on the growth chart.
His height and weight are on the 10th centile. Okay,
Okay.
10th
All
centile.
right. Okay, Adam. Do you feel pain anywhere?
He's saying no pain.
Okay. So, do you go to school?
He's saying yes.
Very good. So we will we will play some games now. Okay. So I want you to walk for me. Is that okay? Yeah.
He's
We walk.
he's looking at his mummy. His mummy is saying to you he cannot walk.
Okay. Will you be able to stand then?
Mom saying that he can stand with crutch. So now there is no crutch, so he cannot stand now.
Mm-hmm. Okay, that's brilliant. So I'm looking on to the legs. Is there any muscle wasting, any scar, or any neurostigmata or anything?
Yes, there are some scars, back of the knee joint and back of the leg. There are some scars. So back of the heel and back of the knee, there are 2 scars.
Okay. Is it on the both legs?
Both legs.
Okay. Is there any contractures?
Mild contracture on the both lower, that is ankle joint.
I'm looking onto the feet as well. Is there any intrinsic muscle wasting or pes cavus or pes planus?
No pes cavus, pes planus, but there is little contracture and there is a little muscle wasting, both bilaterally.
Okay, all right. So I'm gonna move your joints. Okay, if you feel pain at any point, just let me know and I will stop. So I'm moving the foot in this circumduction movement. Is how is the tone? I'm checking both on the feet.
Yes, tone is high.
Okay. So I'm gonna just bend your leg. Okay. If you feel pain, just let me know. So I'm checking for the extension and flexion onto the knee joint on both the limbs. How is it?
Yes, flexion extension is also. What are you doing? Tone, right?
Checking the tone. Yeah.
Yes, tone high.
Okay. So I'm gonna check the tone at the hip joint by doing flexion, extension, and circumduction. And I'm
Yes.
doing on the other as well. How
High.
is the tone at the? Okay. All right. Okay, so I'm gonna check how strong are you, okay? Can you raise your leg above the bed? Is he able to raise the leg above the bed?
Yes, he can.
Brilliant. So let me see how strong are you. So I'm putting the pressure onto his legs. So can you raise your legs now above the bed? Is he able to do that?
No.
Okay. So I'm going to put my hands below the legs. Can you push your legs into the bed?
No.
Okay. So I'm going to ask him to flex his knees. And can you kick me? So is he able to extend his knees?
He can, but no, not pressure. He's not giving you any pressure. He's just touching your hand.
Okay. So I'm putting my hands at the back of the calf muscles while flexing the knee. Can you pull your heel towards your bottom?
No,
Is he able?
he can't.
Okay. So I'm putting the hands onto the hip joint and I'm asking him, can you spread your legs?
He can't.
Is he able to? Okay, I'm putting my hands onto the inner side of the thigh and I'm asking him, can you push my hands?
No, he can't.
Okay. So I'm going to check the reflexes. So Adam, this is just a rubber. I'm going to tap onto your legs. It won't hurt you, but if it will give you pain, just let me know and I will stop. Okay. So I'm going to flex his knee and I'm looking onto the thigh and I'm going to tap onto the tendon. Is there any reflex present on the knee joint?
Yes, reflexes are exaggerated.
Okay, I've checked on the other as well. So I'm going to check the ankle reflex. So I'm going to bend the knee. Can you do like that? Very good. So I'm holding the toes and doing the dorsiflexion, and I'm tapping the hammer onto the Achilles tendon. Is there any reflex present?
Yes, exaggerated.
Okay.
Bilaterally,
wonderful.
bilaterally, same, exaggerated.
Okay, so I'm now checking the planters with the pen. So I'm moving my pen from the heel towards the lateral border and going towards the big toe. How is the planter?
Extensor.
Okay, so I'm doing the clonus now. So I'm going to raise your leg. Okay, it won't give you pain. And I have done the flexion onto the knee, and I am putting the doing the flexion onto the um, foot, like in a jerky movement. Is there any clonus present?
Yes, suddenly you will press, right? Suddenly you will
Yeah.
push.
Jerks.
And yeah, the ankle clonus is present.
Okay, very good. So I'm just now doing a few more fun. Okay, Adam, I hope you're not getting bored. So look, this is a cotton. Can you feel it? Close your eyes and let me know if you feel it. Are you feeling it? Very good. So I'm going to ask you where I'm touching onto your legs. So just close your eyes. Okay. So I'm starting from the feet. So I'm touching onto the big toe. Is he feeling it?
Yeah, he can, but it's impaired. So sometimes he can say, sometimes he can say, I can't feel it. So the sensory tracts are also impaired.
Okay, I'm touching onto the medial leg. Is he feeling it?
Yeah, same, impaired.
And I'm checking it by on the other leg as well, on the same area. Can he feel it?
Same, impaired. Sometimes he can say, sometimes he cannot say.
Yeah.
Proceed. Sensation is impaired. Proceed.
So I'm touching onto the flexor of the thigh. Can he feel it?
Same. I said sensory impaired.
Oh.
Proceed.
Okay, so is there any tuning fork available?
No need. What do you want to do?
Okay.
Mhm.
Proprioception
And
vibration
okay.
and the position.
Examiner said no need. And then next.
Okay, so I'm going towards the coordination now. So Adam, I want you to lift this leg, put onto the shin, onto the knee, and slide it down onto your shin towards the foot. Is that clear? Okay, can you do it now? Is he doing it?
He can't do completely because his
Okay,
power is less, so he can't do it completely.
very good. You are very brave. Can you do it with your other leg now as well? Is he able to do it?
He can do, but not complete.
Okay. All right. So I'm proceed. Do I still have some time?
Yes, you have 5 minutes on, 1 minute left.
Okay, so I'm proceeding towards the upper limbs now. So can you raise your legs above the head? Is he able to raise it?
What test are you doing?
So I'm just checking the power.
Upper limb.
Yeah.
He can do, yes. He can
Okay.
raise his arm above the head.
Okay, so let me see how brave are you. So can you squeeze my fingers? Is he able to squeeze my fingers?
Yes, but power is not very good. He can do squeeze your hand, but not very good power.
Okay, so can you do like this, like a chicken? Is he able to do that position like this?
Okay. You don't have time for individual muscle power checking. Your time is finished. In order to
Okay.
complete what you want to do,
So I want to complete my neurological examination, including the upper limbs and the cranial nerve. I want to do his developmental assessment as well and the skin survey
okay? And
and the head examination as well.
what's in head?
So I want to see the OFC shape of the head, any shunt present or not, any scars over the head, and the sutures, if they are fused or not yet.
If I tell you, if I ask you within 30 seconds, how can you examine upper limb neurology? Which one will you do?
So,
And within 30 seconds.
yeah, so tone and reflexes is the best part to do to see
Right.
if there is hyper
Suppose,
or
suppose the tone of the upper limbs are a little hyper, not in compared to the lower limb, okay? And head, there is nothing in the head.
Mhm.
So what's
And
your
the circumference.
and
What
head
is the
circumference is normal.
okay?
There is no cranial nerve problem. So what is your present, positive finding?
I want to examine the back as well.
Yes, you cannot do it until examiner finished, right? It's a great
Yeah.
mistake.
Yeah.
Okay. Back
Mhm.
examination, do the back examination. Back examination is clear.
Okay.
So what's your diagnosis? Tell me the positive finding.
So I have examined Adam today, who is using wheelchair for mobility, and he has upper motor neuron lesion in form of hypertonia, hyperreflexia, Babinski positive, and clonus is present. His sensations are a bit impaired. There are tendon release scars onto the back of the knee and onto the back of the ankle, and he has impaired sensation as well. It's the upper limbs do have the hypertonia as well. I would putting it all together, it seems like he has cerebral palsy or a spastic cerebral palsy, and seems like quadriplegic. So spastic, quadriplegic, cerebral palsy. My other differential would be any. I would like to take the birth history to see if there is any causes like severe intraventricular hemorrhage, any meningitis, or periventricular leukomalacia or cerebral malformation, any torch infection, any maternal drug abuse. Yeah.
You said spastic cerebral palsy. What type of cerebral palsy it
Yeah,
is?
quadriplegic.
Quadriplegic? What about the upper limb?
So upper limb tone was increased, and he was able to squeeze my hand, but the power was seemed similar as to the lower limb. So all the four limbs are equally involved.
Yes. So in this child, all four limbs are equally involved?
Yeah.
Yeah?
Yeah,
No.
it could be diplegic because lower limb is more involved than the upper limb.
Limbs are mainly, he can
yeah.
raise the hand above the head, okay? So
Yeah.
his
Okay.
power is quite good.
Yeah.
And
Yeah,
tone
diplegic.
slightly increased, but not so much. And see
Yeah.
the position, position of the hand.
Yeah.
See the
Mm.
position he's this is which type of wheelchair. You need to mention during presentation that he's using manual wheelchair. What is
Okay.
the difference between manual wheelchair and electric wheelchair?
So in manual wheelchair, he will be moving his wheels with his hands. So that means the power of the hands are better than the legs.
Right. So you have to mention this, that the wheelchair is manual. So I guess his power is good. Muscle power is good. Okay. And he's moving the hands above the head. So his muscle power is good in upper limb in comparison to the lower limb because he cannot walk independently. Hardly he can walk. And during examination, you missed back, right? Leg, gait, and back. During examination, you asked leg, you inspect leg, and then you ask the gait. Immediately, you should check the back. Am I right?
Yeah. So on the table, on the couch, I should see first the back and then go to the legs. because
Yeah.
he wasn't walking really.
Yes.
Yeah.
You should go back, then you should go leg, because the back examination is mandatory. Why? If you see there is some scar in the back, your
Mm.
full diagnosis will be changed, isn't it?
Mm. Yes.
Yes, your full conception will be changed about the child. You
Yeah.
are not seeing the back. That's why you are not understanding the diagnosis. Is it a lower motor or upper motor? You do not know. But when you see the back, there is a meningomyelocele scar, or there is a dorsal rhizotomy scar, or there is a scoliosis repair scar,
Mm.
or there is a baclofen pump scar. Any scar will guide you, and you know the type of the scar, right? Ugly scar is meningomyelocele scar, right?
Yeah.
So very good. Back examination is mandatory. And then in the lower limb examination, you did inspection, then tone, power, reflex, then you check sensation. Very good. Then you check joint position, joint vibration, that are deep sensation. Very good. Then you check coordination, that is heel shin testing. Also, we can do tap, like foot and hand tap. You will place your hand in front of the foot and the child will tap. That is also coordination testing.
Okay.
You check the mentality. Yes, you check the mentality. Which school do you go? Right? During enter into the station, you checked height, weight, dysmorphism, distress device. Then you check the mentality of the child. Then you check leg gait back. Then you checked lower limb neurology, including motor, including sensory, and then including cerebellum, that is coordination. Then you went to the upper limb. Here you did one mistake. In upper limb, you started power. Power is the less important test because it takes much time. You have to take individual muscle power. Better do the flexion extension of the elbow joint, flexion extension of the wrist joint, and then do the tendon hammer of the elbow joint, tendon hammer of the wrist joint. Easy, 30 seconds. And then yes, you did right that move the upper limb to above the head. You check the power. That's it. You do not need to check individual power because your action is lower limb. But do the upper limb inspection. Like, is there any muscle contracture? Is there any joint contracture, muscle atrophy? Is there any biopsy taken? Check the inspection first. Then you do tone and reflex. Then you go directly to the cranial nerve and head examination. Tell the examiner, sir, I did not complete my examination. I want to do head examination and cranial nerve examination. The child is 7 years, looks quite well, but in order to complete, you have to do developmental assessment as well. Okay?
Yeah.
Now, your diagnosis is not spastic quadriplegia. Your diagnosis should be spastic diplegia. Okay? Because the
Yeah.
upper limb was less involved and upper limb is almost normal. What is the most one important cause of spastic diplegia? One cause, one.
Periventricular leukomalacia.
Very good.
Preterm. Yeah.
Preterm with periventricular leukomalacia. What are the other causes?
It could be intraventricular hemorrhage or maternal drug abuse, torch infection, cerebral malformation, neonatal stroke. No.
Okay. Stroke, bilateral, right?
Perinatal asphyxia.
Cerebral malformation mainly causes quadriplegia, okay?
Yeah. Yeah.
Bilateral stroke mainly causes double hemiplegia, okay?
Yeah.
And so the main causes are like metabolic, okay, genetic, metabolic, and periventricular leukomalacia. This is most common cause. Okay, spastic diplegic CP. How
Yeah.
will you investigate?
So I will do MRI head to look for any structural abnormality. I will do the genetic studies to look for the genetic cause. I will do the metabolic screen to look for the metabolic disorders, including plasma, amino acids, urinary organic acid, amino acid level. I would do the they say
Okay, so you are checking the cause, right? MRI,
Yeah.
MRI, not only the head, you have to do
Spine.
MRI
Yeah.
head and spine both.
Yeah, spine as
Yeah, because we don't know the pathology. We don't know the spinal pathology. The child
Yeah.
is half paraplegic, isn't it? Half.
Yeah.
So spine is a must for this child. And if it is a brain cause, then we know that sometime you will see in spastic diplegic CP, you will see wind swept deformity. Othoba knock knee, you will see lower limb deformity as well. But this child, fortunately, does not have deformity. Why? Because he has got tendon release surgery. Maybe botulinum toxin he got, right?
Yeah.
So how will you manage this spasticity?
So I will involve the multidisciplinary team. So main would be the occupational therapist, physiotherapist for the stretching exercises, and home modification. The other one would be the neurologist for treating his spasticity. First line is the baclofen. We can give it orally intrathecal. Other is botulinum toxin injection. We can do the surgical procedures as tendon release surgeries and dorsal rhizotomy. I would involve the orthopedic as well to assess for his scoliosis or any tendon release surgeries. And I would involve the SALT team to assess for his swallowing, safe swallow. I would involve the school nurse, SENCO, and developmental pediatrician to formulate the EHCP. I would involve what else? For if he has any epilepsy history, so I would involve the neurologist to take care of that. Mhm.
Did you involve developmental pediatrician?
Yeah.
Okay. Physiotherapist, occupational
Yeah.
therapist, orthotic, neurologist for
Yeah.
contracture, right? So contracture, you said baclofen. Why baclofen? What is the mechanism of action of baclofen?
Baclofen is a GABA agonist. It stimulates the inhibitory presynaptic neurons, and it causes relaxation.
It inhibits the transmission of mono and polysynaptic reflex. So it release the spasticity, right? So it is an agonist. GABA is a inhibitory neurotransmitter, no?
Yes, ma'am.
So it stimulates the inhibitory neurotransmitter that inhibit the muscle contracture. So it stimulates the inhibitory neurotransmitter. That's why the muscle contracture become released, right? So GABA, which one is better, GABA or diazepam? Sorry, baclofen or diazepam?
Diazepam causes the respiratory depression, so baclofen is the better.
Superior, yeah. Previously, we used diazepam when baclofen was not so available. And the next option you said what? Botulinum toxin, no?
Yeah.
What is the mechanism of action of botulinum toxin?
It acts locally and it causes the paralysis by inhibiting the presynaptic release of acetylcholine.
Very good. Presynaptic release of neurotransmitter acetylcholine. Very good. Excellent. Well done, Dr. Noor. I'm so proud of you.
Thank you, ma'am.
Nothing to say. Your examination style, your talking with the child was very impressive. Very, very impressive. You did just like the UK exam standard, you know.
Okay.
You did not afraid. You did very well. You take mentality, everything. Your investigation was good. Your management plan was good. Just involve the home modification, school modification, EHCP for this child, right?
Yeah, ma'am.
And that's it. Yeah, that's it. I don't have any further question. Do you have any question?
When I studied, there plenty of questions came to my mind, but no, not at the moment.
Okay, no problem. You can ask me anytime. No problem.
Okay.
Yes.
Ma'am, I have a question.
Yes, please.
Suppose our task is lower motor, lower limb neurology,
Hmm.
and we somehow manage to do the lower limb neurology and back examination within 5 minutes or 5.5 minutes. So
Hmm.
before going the upper limb examination, do we and have to take the permission of examiner, or we can go ahead with the upper limb examination?
No, you can go because your task is to identify identify the case, right? So if your task is to identify the case, you should go to the upper limb, because without upper limb, you cannot understand this is diplegic CP or this is quadriplegic CP. Am I right? So you should not take permission for going to the upper limb. But yes, you should take permission for going to the head examination, cranial nerve examination. You should take permission, and you will not get that much time. So definitely you will tell the examiner, sir, I completed my neurological examination, but I still feel that I want to do examination of the head and I want to do examination of the cranial nerve. Okay. Examiner will tell you no problem in the cranial nerve, because they will not give you a complex child. Okay. Either they will give you quadriplegia, or they will give you hemiplegia, or they will give you diplegia. At 1 or 2 cases, they gave spastic cerebellar CP. 1 or 2 times the child was ataxic, and at 1 or 2 times they gave dystonic CP, because the tone was in one limb, tone was increased, but in another limb, tone was normal. So it was a case of dystonic CP. Okay, so these 2 types of CP are difficult, dystonic and cerebellar CP. Other than that, all CP cases are equal and normal child. I mean, they will not give you complex children. All right.
Okay,
Okay.
ma'am. So in dystonic CP, one side upper limb or lower limb involvement will be there with the
Yeah.
dystonia.
Yes. Dystonia mane ki? Dystonia means abnormal tone. It can be hypo, it can be hyper. Okay.
Twisting movement.
Yes. So no. Twisting movement is chorioathetoid movement. That is not tone. That is move. Okay. Movement is different thing. Chorioathetoid movement is different thing. But tone is different thing. Tone, you are feeling the muscle, right? That is tone. Tone will be dystonic. What do you mean by dystonic? Dystonic means abnormal tone. They did not say hypertonic. They say dystonic. Dystonic means abnormal. So abnormal means if you feel your muscle now, just now, feel your muscle. This is a normal tone, right? Less
Right.
than that is called hypotonia. More than that is called hypertonia. So in dystonic child, the affected part is basal ganglia. That's why if the basal ganglia is affected, what happens? The tone becomes abnormal. So the some part of the body you will find normal tone or low tone. Some part of the body you will find high tone. That's why the child is dystonic CP. Examiner will tell you, suppose this child has a neonatal jaundice, bilirubin induced neuronal degeneration. The examiner is giving you some clue. So you understand that, okay, this is a case of dystonic cerebral palsy. Examiner will definitely give you a clue, because within 5 minutes, a candidate cannot diagnose dystonic CP unless he is a professor of neurology, right? So examiner will give you some clue. Like in my exam, when I passed from Nepal in 2022, in my exam, I told same that, sir, this is a quadriplegic CP. Examiner said, go back and see the upper limb. I saw the upper limb. Upper limb tone was increased, but not like lower limb. Lower limb was much involved. So I told, sir, the lower limb is much involved. Then the examiner said, do you want to change your diagnosis? I said, sir, yes, it is diplegic CP. And when I entered into the room, examiner said, this child was low birth weight, premature and low birth weight, and was ventilated. Okay, so I understood this might be a case of diplegic or quadriplegic CP. So examiner will give you some clue. You will understand, okay?
Okay, ma'am. So in dystonic CP, we can keep one differential diagnosis of monoplegia also.
If only one limb involved, you are right. If only one limb has hypertonia, but if other limb has hypotonia, how will you describe that?
Yes. Then dystonic CP is the first.
Right.
Okay. Thank you, ma'am.
Thank you very much for joining. Anyone has any other question? Anything you can ask? I have 5 minutes left. 5-6 minutes I can give you. Dr. Sabil and Dr. Thashni, I'll take your mock tomorrow. Okay, guys? Sorry, it is very late night now. Many country has 2-3 a.m. So I will take your mock tomorrow. Any question?
Okay,
Anyone?
ma'am.
Anyone has any question? So how much you liked, guys, our mock session? This is our daily practice. We do daily like this type of mock, okay? And we laugh, we smile, and then we cry. Sometimes we scold, okay? Sometimes we laugh out loud. This is the daily practice we do. If you liked it, please give us some thumbs up in the Facebook. I would like it, your comments. And inshallah, I will soon meet you again with some interesting cases, video station, maybe communication. Okay, just pray for me so that I can have some free time. Inshallah, soon we will meet again. Okay. Thank you very much, everyone. And the 3 mock candidate, you are most generous that you contributed today. Thank you very much.
Thank you to you, ma'am.
Thank you very much. Bye-bye.
Bye.
Do we get the recording?
You want this recording?
Yeah.
Okay, who is that? Dr. Cyrene. Okay, Dr.
Yes.
If you are in any of my Facebook group or any of, just put a message. I'll try to post. Okay.
Okay. Thank you very much.
And do not forget to give us some feedback in the Facebook channel, please. I hope you all are in my Facebook channel because you joined from the Facebook channel, right? So you all are in my Facebook channel. Please give some positive feedback or negative feedback, whatever you want. Just give some feedback so that we can show this, that we are having some teaching sessions that is free for all, and you are getting benefit, right? So
All right.
inshallah, see you again. Bye bye. Thank you.
Thank you very much.
Thank you very much. Bye.
Bye.